Again, I'm Jamila Winter. I'm one of the first years, and welcome to all the applicants. Okay, so we're going to start off briefly with a case. So we have a 70-year-old woman with a history of non-alcoholic liver disease who has evidence of mild portal hypertension on imaging, who presents to the hospital with melena for about 2 weeks. She does have a history of chronic iron deficiency anemia requiring iron infusions as an outpatient, and intermittent blood transfusions as well. She did have an EGD in 2018 for essentially a workup of IDA, and it showed atrophic gastritis on path. And on arrival, she had a hemoglobin of 4.2, which was about 3 points, around 3 to 5 points less than 3 months prior. And she had evidence of iron deficiency anemia consistent with her prior kind of presentations, despite IV infusions kind of in the outpatient setting. And so obviously she warranted a EGD. And this was what we saw during her procedure. So on the left here, you see these red linear striations that are in the antrum of the stomach leading up to kind of the pylorus, the pyloric area. And on the right here, you see oozing from these lesions, presumably the cause of her melena. And ultimately, her lesions were treated with this little device here called APC, argon plasma coagulation, which is essentially, it's almost like cautery, and it, we buzzed the lesions to essentially stop the bleeding. The lesions were so diffuse that we didn't get everything, but we probably got around 90%. And so ultimately, this patient again was treating with argon plasma coagulation. She was started on pantoprazole 40 daily and continued on IV iron as an outpatient given her persistent iron deficiency anemia. And then the ultimate plan was for her to follow up in clinic for a repeat hemoglobin in about 2 to 4 weeks. And if she continued to be symptomatic, so if she continued to have melena or if her hemoglobin was downtrending, the plan was to repeat the EGD with possible APC. And so these lesions, I'm sure most of you are familiar, but just for a good review, this is called Gastric Vascular Ectasia, or GAVE. And so we're going to go into a little bit about what GAVE is. And so ultimately, GAVE is small vessels or ectatic vessels that appear to be multiple red linear lesions at the apices of the antral folds that radiate to the pylorus, also known as watermelon stomach. This is actually a pathognomonic for the disease process. Sometimes it can be punctate as well. It's not only linear. It's actually quite rare. About 4% of upper GI bleeding that's non-variceal will be GAVE, and almost always it presents in a woman at the average age of 70, similar to the patient that I presented to you earlier. She was actually kind of a classic textbook patient for this particular case. It actually commonly presents as occult bleeding that manifests as iron deficiency anemia. And so patients, usually about 60 to 70% of them, become transfusion dependent, and that's blood cell transfusion dependent. It doesn't commonly actually present with overt GI bleeding, similar to my patient. So she was actually kind of a little bit an anomaly, and not necessarily an anomaly, but she was atypical in that sense. It is almost always associated with a common chronic disease processes, such as liver cirrhosis, kind of connective tissue disorders such as Sjogren's or systemic sclerosis, renal insufficiency, and atrophic gastritis. There have been case reports that do show some connection to other chronic disorders like chronic hypertension and thyroid disease. And the pathogenesis of this disease process is actually unknown. It's thought to be multifactorial from mechanical stress, in the sense of strong peristalsis, thought to be induced by the prolapse and trauma of the antral mucosa. Hormonal factors, actually these patients tend to have increased levels of gastrin and prostaglandin, which are often seen in liver patients because of buildup and liver processing dysfunction. And then autoimmune factors. So about 60% of patients who have GAVE have associated autoimmune disease. They will test positive for ANA or anti-centromere antibodies. So it's thought that there is some autoimmunity potentially to this kind of finding. And so this is just a brief slide on the difference between GAVE and portal hypertensive gastropathy. And the reason why I included this is that sometimes endoscopically, the two disease processes can appear the same. And so just for a brief reminder, so on the right here, this is GAVE, again, kind of the linear red striations in the antrum of the body. Portal hypertensive gastropathy is almost always seen actually in the body or the fundus of the stomach and not the antrum. The demographic or the patient that both of these two disease processes can be found in are oftentimes patients who have liver disease and kind of liver dysfunction or some kind of portal hypertensive process. And so that's why it can be hard to differentiate. Here you can see in portal hypertensive gastropathy that the endoscopically, it's actually more snake-like and kind of mosaic pattern. So that's another differentiating factor. If endoscopically it's hard to determine the difference between the two, actually we can look at it both, kind of disease processes look very different histologically. So GAVE actually has this like fibrinous deposits in the mucosal capillary here that's starred, but the portal hypertensive gastropathy past slides usually show clearing of the capillaries. Actually getting histology is not needed for the diagnosis of GAVE, and actually for our patient that I presented on the first slide, we actually did not get biopsies for her. And so how do you manage these patients? So the first line is actually endoscopic, similar to what we did early on with APC. The other kind of endoscopic therapies that have been shown to be just as efficacious as APC include laser, cryotherapy, bend ligation, radiofrequency, and ablation. Maybe kind of later after the talk, one of our, maybe Satish or one of our advanced endoscopists can talk a little bit more about the differences in all of these, but APC is widely used across institutions because it's more cost effective and actually has been shown to lead to less complications. So medical therapy is actually fallen out of favor because there's actually no clear kind of improvement in either rebleeding rates, mortality, hemoglobin levels when using these medical, kind of like these medications when we look at them in certain trials. And so they've fallen out of favor, and we actually don't really use these anymore as first line in managing GAVE. And then the definitive management actually surgical is enterectomy. But as you can imagine, this can lead to kind of high rates of mortality and morbidity. And so that's also that's not used frequently, but can be used if patients have so severe, profound symptoms and refractory symptoms that are not well managed with endoscopic treatment. And so unfortunately, there are actually there are not that many randomized controlled trials looking at the different therapies for GAVE. There are several meta-analyses and systematic reviews looking at kind of the different therapies that I mentioned earlier. This one that I found in Clinical Gastro and Hepatology in 2014 is one of the larger meta-analyses looking at I think about 60 studies spanning from 1980 to 2013. And ultimately, what was kind of concluded was, again, that medical therapies had no clinical role in GAVE, and that APC, laser, and banding are almost all comparable, but APC wins in the sense of having maybe potentially having less complications and being more cost effective. On average, they saw that patients will need to be treated anywhere from 1 to 4 times with APC or laser to have, for 80% of patients, to have about 90% more resolution of their symptoms. So it's actually they're quite effective therapies for GAVE. But unfortunately, about 40% of patients on average will need kind of another kind of treatment in 1 to 2 years after their first treatment with both APC and laser. And so this was actually the only randomized controlled trial that I could find looking at the difference between endoscopic band ligation versus APC in treating GAVE in about 88 patients who had cirrhosis. And they looked at multiple outcomes, a lot of secondary outcomes, including hemoglobin levels, rebleeding rate, mortality, blood transfusion units, treatment sessions, complications. And ultimately, there were no difference between the two therapies, except for what I think is probably only the most effective outcome is like the treatment session. So band ligation on average required 1 less treatment session, about 2.93 compared to 3.54 of APC. And that was statistically significant. Banding also required less blood transfusions, for what it's worth, about an average 2.5 compared to 4.6 in APC. So perhaps banding is more effective in that sense, but I think in everything else, both therapies again are very comparable, and I think ultimately the same in complications as well. So there are no guidelines for managing GAVE, not that I could find. There are a lot of proposed algorithms that have been kind of proposed in several articles and journals, and this is one that I really like, and one that I think I've seen in the very few months that I've been a fellow, but this one is in alimentary pharmacology and therapeutics. And ultimately what this is saying is that if a patient has been diagnosed with GAVE, upfront treatment is iron therapy, transfusions, and then treating with APC, similar to the patient that I presented on earlier. Repeat a hemoglobin in 2 to 4 weeks. And the patient continues to be symptomatic or is downtrending, then technically should be repeating the sessions up to maybe 4 sessions, which I guess this number 3 to 4 is what has been kind of documented in prior literature. And if there is a response, great, you can follow up with the patient. I think, guidelines on follow-up again are essentially non-existent, so that's per judgment of the clinician. But after 4 sessions, if there's no control of the bleeding or symptoms, then consider banding. And if the patient continues to have refractory symptoms, then can consider more kind of definitive treatment, such as surgical endarterectomy. And so kind of in conclusion, so watermelon stomach is a classic endoscopic finding of GAVE. I think this is important for mostly, border view. So if you think of a patient, a woman who's elderly and has refractory IDA, chronic illness such as cirrhosis, connective tissue disease, and renal insufficiency, GAVE is something that we should be thinking about as a differential. Histology can help differentiate between GAVE and portal hypertensive gastropathy. APC is kind of widely used as main treatment option to manage GAVE, but bond ligation may be more effective based on that one randomized control trial. And then unfortunately, there are no set guidelines on the management. So we need more RCTs to help us guide our clinical reasoning and our management of these patients who present with GAVE. And that is the end of my presentation. I'm wondering if anyone has any comments or questions for me.
Awesome. Thanks, Jamila. It's sort of interesting. It's been like the season of GAVE and radiation proctopathy. I feel like we're getting like a consult a week from the general service for treatment of this. there's every few years there's another study that shows how good RFA is in refractory GAVE. And so APC often is frontline, partly because it's just easier to access. The thing to caution is that after you APC that much of the stomach, patients feel horrible. Like they are, because everything, it ulcerates. When you go and scope them a week later, they're just all ulcerated from all of that cautery. So it's good to be on acid suppression, maybe some Carafate, and just really warn the patient that it's not going to feel great. I've never done band ligation. Again, every couple of years there's another study on band ligation. And there's multiple studies now that show that it's quite effective. I think Chris has done it once, maybe not the best results. It's a lot of scarring potentially. I don't know, Chris, if you want to share your experience briefly.
Yeah, it's funny. I saw it once during my fellowship training, and then I've done it once since then. And it was a woman who had refractory, she had severe GAVE in and out of the hospital, the whole thing, symptomatic anemia. And she was refractory to APC. And this was really before people started doing RFA. So this was really the only other option. And we banded about 50% of the antrum. Immediately I knew it was going to be an issue because it occluded her pylorus. I mean, I thought liquids and stuff could snake through, but I was really curious as how is food going to get through, which was an unexpected sort of consequence. She had pain when she woke up. We managed to get her home, and when she got home, she had severe retching and vomiting, and she popped her bands and had more bleeding and had to go to the local hospital for treatment. So that was the first and probably last time I've done banding.
Yeah, and we were, Jamila, that was a great presentation. Thanks very much. But we were actually interested, a couple of us were sort of chatting while you were doing it about, have you ever used banding for this? And the four of us decided Chris was the only one who maybe had. I mean, it's interesting that there's a randomized controlled trial or meta-analysis, I guess, you showed that sort of points toward that, because typically I think all of us use superficial thermal type therapies or cryotherapy, which is sort of a thermal therapy in a different direction.
All right, we have two other cases, so I'd like to turn it over to Steph Rutledge.
Perfect. Thank you, Satish. Let me just share my screen. Great. Can you see my screen?
Yes.
Okay, perfect. So welcome to the applicants. My name is Stephanie Rutledge, one of the second-year fellows, and I am presenting a somewhat selfish case today because I don't know what to do with her. It's a lady that I scoped last week, so I'm really looking forward to hearing people's input. So the case is a 41-year-old transgender female, meaning male at birth and transitioned to female last year, who has HIV and is on antiretrovirals, a viral load of 2,000 with an unknown recent CD4. But my suspicion is that if she has no known recent CD4 count, it may not be that great, because most of the patients who have a good CD4 count will know their CD4 because they're following up so closely. She presented to GI clinic with abdominal pain, early satiety, and a pretty concerning weight loss of 40 pounds in the prior year, had no dysphagia or odynophagia, which will be important later on. She did not drink alcohol, was a former smoker. Her exam was unremarkable, and she was anemic, but not really iron deficient, sort of a borderline transferrin saturation, and then a very normal ferritin. This is what her EGD showed when I did her EGD during outpatient scopes last week. So here we are coming into the esophagus and immediately sort of overwhelmed by these sloughing sort of areas of white exudate throughout the mid to distal esophagus. And at the end, you saw there was maybe there's sort of the illusion of perhaps a ring, but lots of exudate, which was difficult to wash off. And then when we sort of washed underneath it, we saw that it was erythematous and looked inflamed underneath. So let me show you. Oh, and here's what looks like the illusion of a ring. There's sort of an abrupt change here to normal mucosa, but it might just be that everything is so inflamed that it's sort of more of a dramatic transition. So these are some of the slides. On the left here, you see just like peeling off of sloughed off exudate off the side with like an erythematous stripe here. And then you just get a sense on the right of how how extensive the sloughing was, although the mucosa underneath doesn't appear ulcerated or too abnormal. So I was eagerly awaiting her pathology, and I was sort of disappointed when it came back. I was phoning them yesterday just to get the final report. She has mild chronic non-specific esophagitis. We did biopsies and brushings, and the brushings were negative for malignant cells and negative for GMS, so no candida, which was what we were suspicious for. So maybe at the end, I would love people to weigh in on what this might be, whether it still is candida with the negative biopsies and cytology. What I did was I increased her PPI to try and improve her symptoms. And I was planning to empirically treat her with fluconazole, but maybe I'll decide at the end of this talk. I just wanted to do an overview on upper GI symptoms in the HIV positive patient, which I think is not something that we see all that often with antiretrovirals. It's less common to see these HIV or AIDS related manifestations in the upper GI tract. But I think with a CD4 count of over 300, you're really looking at the pathologies that affect the general population. So I think the reflex should be sort of like when we hear there's melena, our reflex is what does the rectal exam show? For a HIV positive patient, when you hear HIV, you shouldn't be jumping to CMV or Candida. You should be asking what their CD4 count is, because if it's over 300, 400, then you're looking at causes that are as common in the general population. So things like GERD, piloesophagitis, especially from things like AZT or doxy, altered motility or achalasia. There is some evidence that HIV itself can affect the nerves in the esophagus and cause esophageal dysmotility. And there are some rare case reports of HIV causing achalasia. But those are sort of rare. So I think piloesophagitis should be on the top of the list, especially if they're taking either antiretrovirals or bacterial prophylaxis. With a CD4 count of less than 200, you're sort of getting into the realm of more HIV or immunosuppressed specific pathologies. So candidiasis is by far and away the most common cause of dysphagia or dynophagia in a patient with a CD4 count less than around 200. That's extremely common. In fact, so common that before the advent of antiretrovirals, so in the early 90s in France, oral candidiasis was the second most common AIDS-defining illness there. And if you were diagnosed with CMV esophagitis back in that time, your life expectancy was on average about 5 or 6 months. So some of these pathologies really hark back to before the advent or before antiretrovirals were widely available. Although unfortunately in some of sub-Saharan Africa, many of these pathologies are still happening due to lack of access to the antiretrovirals. But the other thing to think about is HPV or squamous cell carcinoma. That seems to be slightly increased in HIV positive patients and can be sexually transmitted. The other thing, which is rarer but can occur pretty much at any CD4 count in the 200, 300 and below range, would be Kaposi sarcoma, which rarely affects the esophagus, as well as lymphoma. They're pretty rare, but something to be on the lookout for. And then when you really get into sort of the AIDS CD4 count level, you have CMV, which is more common than HSV. And then these idiopathic esophageal ulcers, which are thought to be perhaps related to necrosis of healthy cells around the HIV cells, which can sometimes be found in the esophagus themselves, but we think it might be a direct cytopathic effect from HIV on the esophagus. They cannot find any organism in these ulcers, but they have seen them in HIV positive patients with a low CD4. And then you move into the realm of very rare fungal illnesses, like I've described here on the slide. So again, a really idiopathic esophageal ulcers, before antiretrovirals, they were associated with a life expectancy of just 13 months. So really, really poor, and CMV just 5 or 6 months. So they're the things that you're looking for in someone who's really immunocompromised. And interestingly, these pathologies are more common in patients with HIV compared to patients who are immunosuppressed on something like anti-rejection meds for an organ transplant. So we think that there's something directly related to the HIV that may be predisposing people further to these pathologies. Here are some of the different esophageal findings that you can be on the lookout for if you're doing an EGD in someone with HIV. So the candida has that classic cottage cheese appearance. The plaques are difficult to wash off, and you can do biopsies or brushings, which I'll talk about a little bit later on. Then you have the HIV or the HSV ulcers, which are these like small volcano-like appearance. They're more shallow than the CMV ulcers, which are deeper, more longitudinal, and they can be like linear, stretching down the esophagus. And just to remember, CMV center. So I remember C with C. You should biopsy for the center because you find from the center because you find more of the cytopathic effects in the middle of the ulcer, which is helpful to make your diagnosis on pathology. HSV, you biopsy from the edge. And here are some of the pathology findings. So the HSV esophagitis, there's multinucleation and there's margination. Maybe one of the pathologists would like to comment on this later on. Whereas CMV esophagitis, I think from our USMLEs, we find maybe easier to recognize because there's this prominent intranuclear basophilic inclusion, typically with this clear halo surrounding. So almost like an owl's eye. Oral candidiasis is one of the most common AIDS-defining illnesses before antiretrovirals. And you can see, even if you have a CD4 count of 200 to 400, about a third of those patients will have some mild candida in the mouth. And if you have AIDS, it's 90% of those patients will have oral candidiasis, so very, very common. Esophageal candidiasis is considered an AIDS-defining event, or it was in the past, less so now. In endoscopic surveys, however, you can find esophageal candidiasis in about 40% of asymptomatic patients with HIV. Interestingly, as we have used more fluconazole, we're having the emergence of these non-albicans candida species, and they can cause refractory mucosal and even invasive candidiasis. And there is more of a resistance to fluconazole, although they have all been shown to be sensitive to voriconazole. And 1/3 of patients with candida esophagitis don't have thrush. So I think it's important to look in the mouth when you're worried about candida esophagitis, but just remember that only 2/3 of those patients will have oral thrush. The others may not have any abnormalities in their oropharynx at all. And just to think about it, that actually when there's esophageal candidiasis, you can have concomitant infection with other viruses like CMV in just over 20%, or HSV just in 2%, or you can have bacterial superinfection of the ulcers or the esophagitis. So there might not just be one pathology. It's important to think about. The study that I pulled up was the biopsy versus brush cytology in esophageal candidiasis, because I have done EGDs with different attendings who have advised doing different things. So I've heard before that if you take the biopsy, the candida might fall off the biopsy specimen inside the formalin, so then you won't get your diagnosis. But then brushing is a little bit more tedious and is just a little bit more time intensive in the endoscopy suite. I don't think we ever have a brush in the room, and it can take a little bit longer. But in her case, neither came back positive. So I did a quick literature review of what is recommended, and there is very, very little evidence recommending either. There was this retrospective review of patients who underwent an EDD evaluation for suspected esophageal candidiasis, and they had to have esophageal symptoms, endoscopic evidence of candida, and have had both biopsies and brush cytology done. They included 55 patients who had both, and they defined esophageal candidiasis as the pathology, i.e. the biopsies positive for candida with esophageal symptoms, and all of them had the macroscopic appearance suggestive of candida. The age on average was around 51. They were roughly half male, female, and just over 40% were immunosuppressed. And 11 of those were positive for candida. So 11 out of the patients, 55 patients who had an EGD suspecting for a suspicion of candida. And so looking at the table that they put together, the sensitivity of brush and biopsy are both pretty high, but the specificity is much lower for cytology, for the brushings, whereas the mucosal biopsy has a much higher specificity. What I don't understand though is that the biopsy was the gold standard. So it is 100% sensitive. And I just wondered if it's possible that the cytology was actually picking up cases that the biopsy was missing. And they're calling it less specific, but maybe it is actually catching cases that the mucosal biopsy isn't. I guess if both are positive, it's helpful, because then you feel sort of comfortable with the diagnosis. In her case, I would have taken just one being positive, because that's what it looked like. and we don't know what her CD4 count is, so I was suspicious for Candida. But unfortunately, we have both negative. So to summarize, mucosal biopsy is the preferred endoscopic sampling for the diagnosis because it's more specific, but the sensitivity of brushing and biopsies are both high. And I would love if anyone has any thoughts about what I should do with this patient. I was going to give her a call today, so any of your ideas would be much appreciated. Thank you.
Thanks, Steph. That was a really thorough and good overview of so upper GI and HIV, and we don't see it as often. It's good to be reminded of it. There's a few people in the chat box talking about maybe that looked a little bit like discriminative esophagitis or esophagitis desiccans superficialis, which is a little bit what that like peeling squamous mucosa looks like. But the problem is it doesn't help you with what they have because it's sort of a reactive, hi, I'm sick kind of process. But we already know that. Some of those, I mean, it's hard in the video, it gets a little choppy on Zoom, but I didn't know if they almost look like squamous papillomas, some of the sort of solid lesions, but maybe that was all just bunched up mucosa. Certainly not unreasonable to empirically treat, I think, for Candida. There's a little downside to that, and it's so common. Is there a sampling error here? And then can repeat your scope and sort of see what happens after it clears. Other comments from the audience?
Yeah. I have one.
Go ahead.
Go ahead. No, go ahead, Dave.
No, everything Satish just said I'd agree with. The deep ulcers that you described, they were shown on electron microscopy. The idiopathic ulcers in HIV, and those of us who are a bit older, I mean, we used to see this constantly, and it went away with much better treatment for HIV. So all of this is much less frequently seen now. But the CMV, HSV were the two main ulcer-causing things. Candida caused dysphagia as well. But the deep ulcers that you described, that you ascribed to HIV, if you looked on electron microscopy, you found HIV in it. And they responded to thalidomide, interestingly, as another treatment. But that's not relevant to your patient at all.
Interesting, though.
Yeah.
I was just going to make the point that the reason you biopsy the edges of the ulcers in these rule out viral or viral ulcers, the reason you biopsy the edges with HSV is because the herpes virus infects epithelial cells. And the reason you biopsy the center of the ulcer with CMV, because CMV causes a more vasculitis and it's more an involvement of the vessels. And my understanding is that the pain associated with CMV, we see CMV colitis and we see CMV ulcers, is kind of like an ischemic phenomenon from the infection. So that's the reason why you take the biopsies from those specific sites.
All right, Nick, do you have a case for us as well?
I do. Luckily, I am well practiced in presenting it in exactly 6 minutes, so I think we'll be okay. Hold on, let me pull it up. Okay. So, hello everyone, my name's Nick. I'm the Advanced Endoscopy Fellow here at Mount Sinai, and today I'll present everything plus the kitchen sink endoscopic management of a chronic gastric fistula after laparoscopic sleeve gastrectomy. So first for the case presentation, our patient is a 34-year-old female with a history of obesity, status post laparoscopic sleeve at an outside hospital in 2013. She did have an early postoperative leak, although we don't know all the details of the interventions because we just didn't have the records, but she came to MSH 6 years later with fever and left upper quadrant pain. Presentation, she was afebrile but tachycardic. Exam was notable for abdominal tenderness in the left upper quadrant, and labs notable for a mild anemia. Initial imaging showed a perisplenic collection, which was actually drained by IR. And she went an upper GI series that shows this very abnormal looking sleeve with extravasation suggestive of a leak. So we took her for endoscopy for closure of that leak. On initial endoscopy, upon entrance past the GE junction, became apparent her sleeve was very abnormal. So the opening to the sleeve is here on the bottom, and on the top, there's this proximal ulcerated outpouching with a fistulous tract. And the tract was investigated with a wire, and it's actually a complex fistula. It communicates with the sleeve itself, and you can see the wire popping out through the sleeve opening here. And on fluoroscopy, it actually also communicates with an extraluminal fluid collection. So that picture on the right is the wire going through the fistula into an extraluminal space. On the initial endoscopy, the treatment modality chosen to close the fistula was fibrin glue injection, followed by placement of a covered metal stent, an esophageal stent, across the fistula to sort of seal it off and allow it to heal. And the stent was sutured in place. And here's the final fluoro from the stent placement. And after a 10-day interval, she had follow-up imaging. The perisplenic collection improved with IR drainage, although she did have a new perigastric collection with air in it. And unfortunately, she didn't tolerate the stent. So she had a lot of pain, and the decision was made to remove the stent and try a different mechanism of fistula closure. So on her second endoscopy, the tract, this whole outpouching was treated with circumferential APC, as you can see here. The idea being that this would aid in tissue apposition for fistula closure. So this whole tract is APC'd. And then again, endoscopic suturing is employed to close this whole area off. So this is the tissue helix, pulling tissue within the suturing device. And then this suture is fired through the tissue. There are several more steps that are not well documented here because it kind of goes in fast motion, but that suture, there were 2 interrupted sutures placed. And this is the suture being cinched down. But the final result is that that area is completely closed off. So the only opening is the sleeve opening there. So after this, she had repeat imaging at a 2-month interval. The perisplenic collection completely went away. The perigastric collection got better, and she did great for a year. She went home until a year later, then she had recurrent pain. So she came back and she still had a leak. She had an enlarging perigastric collection and a persistent leak on upper GI series. So she was taken for a 3rd endoscopy. And at this one, instead of attempting another fistula closure, because we had tried multimodal therapy at this point, which was unsuccessful, we attempted a different mechanism, and which is called endoscopic internal drainage, and I'll explain that. But again, she has this abnormal sleeve, the opening on the right, and then the little outpouching on the left. There are 2 visible fistulous tracts. One has pus coming out of it, and a wire, again, shows a complex fistula communicating with the sleeve here. And actually the 2 fistulas connect with each other. So there's a wire going in one to an extraluminal space, as you can see on fluoro, and then the wire comes out the other fistula. So the fistulous tract is dilated to allow for a combination of stents. And then 2 plastic double pigtail stents are placed through the fistula into the collection. And the idea being that the collection can drain internally through these stents, and then the stents will allow the tract to heal. And this is the final fluoroscopy showing the stents in place. And follow-up imaging, just documenting the stents are in that collection where we expect them to be. She actually did well. Unfortunately, actually, not last night, but the night before, after I'd already prepared this presentation, she actually came back about a month after this last endoscopy, and she has recurrent pain and enlarging collection. So this case is still a little bit unfinished. We're trying to figure out what to do. She might end up going for surgery. But I think the learning points are overall endoscopic fistula management. We can talk about, especially relevant to gastric sleeves because they have a high leak rate, up to 2.4% in a large meta-analysis. And acute fistulas have a pretty high success rate of closure with endoscopy. So a variety of methods have been tried. We demonstrated a few there: the fibrin injection, suturing, stenting, APC. Sometimes over the scope clips would be appropriate, although in this case it was just too large to accommodate a clip. But the delayed closure of chronic fistulas is much more difficult and often requires multiple sessions or multimodal therapy. So endoscopic internal drainage is one emerging therapy for chronic fistulas, and it's been applied to sleeve leaks. In this large case series of 67 patients, 78% of patients were cured by endoscopic internal drainage, although it did require prolonged treatment and often multiple sessions. All of the failures in this study were, as expected, chronic fistulas. Although they did succeed in closing some chronic fistulas, they did fail in several cases. And the main complications were pneumoperitoneum, which was managed conservatively. One patient had intraprocedural sepsis, which required surgical drainage. And then several patients had stenosis after treatment requiring pneumatic dilation. And that's it. So I'll take any questions. Again, like, unfortunate that she's actually back and we don't have a great solution, but I think it just demonstrates the complexity of this problem.
Nice work. I mean, you know, the problem is that there's no easy solution here. I mean, if surgery was an easy no-brainer, you know, that could have been attempted quite a while ago. But with these chronic tracts, it's going to be a mess in there surgically as well. So, be curious to sort of see what the next step is for her. Is she going to lose her pouch, or are they going to try to just staple it down? Anything, they have a new staple line, there's a new leak risk. So
I spoke with the surgeons last night about her case. You know, the thought process on how this outpouching and fistula, chronic fistula, ended up forming was probably a result of an incisura stricture years ago when she had her initial sleeve done, and then we're dealing with all the chronic complications with the outpouching and the fistula. But the plan tentatively is for her to have these stents in place to allow drainage of that collection where we saw pus coming out, and then the surgical plan is in a week or a couple weeks to do a sleeve conversion to a roux. They just don't think that there's enough for them to try to staple across to salvage the sleeve anatomy, so they'll convert her to a roux. It's going to be a complex surgery, but I don't think we have any additional great options for her endoscopically. One of the ones that we had talked about as a team was endovac therapy, but it's a challenging case in her position because of that sort of outpouching that's there, and then there are fistulas within. So I think surgery will ultimately be the best for her in this case.